Hello, everyone, and welcome to today's webinar. My name is Olga Beatty, and I'm a Syngap parent and part of the team here at Syngap Research Fund. Our presentation today is discussing Syngap1 related developmental disorders. And I have the pleasure to introduce today's speaker, Dr. Holly Harris. Dr. Harris is the Assistant Professor of Pediatrics at Baylor College of Medicine and practicing physician at the Meyer Center for Developmental Pediatrics, which is a part of Texas Children's Hospital here in Houston. She obtained her Bachelor of Science in Biology with a minor in Medical Humanities and Chemistry at Baylor University. Preceding this, Dr. Harris received her Doctor of Medicine at Baylor College of Medicine in 2012, and she completed her residency in pediatrics at Boston Children's Hospital, where she also received a fellowship. Dr. Harris has received many awards, and she's committed to providing family-centered and evidence-based care for children with neurodevelopmental challenges. Her research interests are in autism spectrum disorder, to include Syngap1. Dr. Harris' clinical interests include autism spectrum disorder, intellectual disability, ADHD, learning disabilities, anxiety, genetic and metabolic disorders, behavioral concerns, and prematurity. A recorded version of this webinar will be available on the Syngap Research Fund website under the Resource tab. And by the end of this presentation, you'll have the opportunity to get the answer to your questions, and we'd love to hear from you. So please write your questions in the Q&A below. For those of us just joining us, welcome. And again, our speaker today is Dr. Holly Harris, discussing Syngap1 developmental related disorders. It's now my pleasure to turn things over to Dr. Harris.
All right. Well, it is really a pleasure to be here. Let me go ahead and share my screen so that I'll have my slides up there. Can you see that? Maybe I can get a nod from.
Yes.
All right, perfect. Okay. So yeah, like I said, it's an honor to have the opportunity to speak to you all, and hopefully you'll find this information useful. And I do hope to leave plenty of time for questions. So if I don't cover your particular question during the talk, there will be plenty of time for that at the end. All right, so my learning objectives are for you to understand the range of potential developmental outcomes for individuals with Syngap1 mutations, to understand the definitions of autism and intellectual disability and the overlap and distinction between the two, and to know some of the optimal therapeutic and educational interventions for these developmental conditions. And so I'm gonna move my screen around just a second. Okay, perfect. So I wanted to start right off the bat with what we do know about Syngap1 related developmental diagnoses. And a lot of this comes from cases that have been reported in the literature and that have been described thus far. So whenever we as clinicians learn about a new genetic finding that might have implications on medical or developmental outcomes, then we start to try to kind of gather that information collectively. And as soon as we find several individuals who have a genetic diagnosis and we see kind of what it's, how it's impacting their neurodevelopment, then we'll try to put that out there in the literature via case report. So some of you may have even gotten to an echo, I think. Okay, I think we're good. Some of you may have even gotten to read some of those, or that's where you kind of first learned about what to expect. But what we do know from what has been published thus far is that intellectual disability is pretty universal. I think a lot of the rates that I've seen are about 96%, and epilepsy as well. And those are usually myoclonic seizures, absence seizures, and the like. And then there are a proportion of individuals with Syngap1 mutations that will have autism, usually ranging from about half to 75%, depending on kind of what study or what case series that you're looking at. And then ataxia, unsteady gait, that's another very common feature. A few distinct behavior difficulties, particularly some risk of aggression and perhaps self-injury in some individuals, a lot of impulsivity, and then sleep challenges as well. And I'll also say that we have realized that there are some significant differences in sensory processing. So how the individual processes sensory information either is very overstimulated by sensory information or sometimes hyposensitive. So things that would bother someone, like pain or something like that, may not be as easily perceived in Syngap1 mutations. And so I wanted to go into this in a little more detail based on individuals at our center. So I work at Texas Children's Hospital with Dr. Jimmy Holder, who does a lot of work in Syngap1. And there was a report in 2019, it's there at the bottom, the author's name was Dr. Jimenez Gomez, but it went through 15 cases that have been seen at Texas Children's Hospital. And I'm going to give you an overall synopsis of that. So what we learned is that the average age at diagnosis, well, really, I shouldn't say the average age. What I should say is that the age at diagnosis had a huge range. So some children were recognized before 3 years, but then there were some individuals that their Syngap1 mutation wasn't found until about 14 and a half years of age. We did see that there is what we would describe as a plateauing of development around 5 years of age, and doesn't mean that a child can't learn new skills, but I think we do see that in terms of kind of making large gains in developmental skills, whether that's speech and language, motor, gross motor, fine motor, adaptive skills, that kind of do hit a bit of a plateau after age 5. But the timing of when children would gain certain skills was also variable in our population. And so what I mean by that is, if you actually go in and kind of look at the paper, there's a wide range of some children gained these skills much earlier than the average that I'm reporting here, and some it took much longer. But on average, the first word was around 3 years of age. Children sat around 10 months of age and walked around 24 months of age. Scribbling and use of utensils, so the ability to use one's fine motor skills and hands, usually that was a bit longer before that skill was acquired, so maybe around 4 years of age. And again, these are kind of just the mean based on those 15 cases. And we also saw that overall, all individuals had moderate, severe, or profound intellectual disability, although there was one individual in our case series that had mild intellectual disability, which was a bit unusual compared to what is seen kind of on the broader scale. I did talk to Dr. Holder about this a little bit, because I was curious if he thought that there were, certain aspects of the mutation that can kind of help us predict children that might not have as severe cognitive deficits. And he really couldn't give me a straightforward answer. He said, not especially. There are some mutations at the 5' edge or splice site variants that can maybe indicate that there may be a milder presentation, but he's like, up until this point, I haven't kind of seen any hard and fast rules around that. And so I also listed here kind of the highest skill that was described for some of these children. So for gross motor skills, walking up and down stairs and jumping, fine motor skills, kind of feeding oneself with utensils, expressive language, so what we're actually able to say or communicate, whether that be speech, signs. Several children have had 5 to 6 signs. Others, some children had 2 to 3 word sentences. And the vocabulary ranged, everywhere between 1 to 250 words. And receptively, kind of the maximum level I saw described was 1 to 2 step commands. And again, this was kind of based on the notes that already existed within our medical records here. So I think one other thing I'll mention here, and that someone kind of was inquiring even before the talk began, is are there things that can hint us to Syngap1 mutation early? So what can we be looking for as clinicians or as parents to kind of let us know that perhaps we need to do testing for a Syngap1 mutation? And it's still challenging to say. I will say that kind of, I'm going back to this slide here because you can see that in general, for a lot of our kind of developmental milestones, children with Syngap1 mutations are taking about twice as long to meet that milestone, or even longer. So a first word, we think about it around a year. And so the mean age was around 3 years. Sitting, we think about it 6 months. It's almost double that before the child is reaching that milestone. Some of the first milestones that you see or that parents can recognize are those gross motor milestones, like sitting and walking. And so if you already are seeing delays in that the child is 6 months and really not sitting, has a low tone, That to me is definitely an indication to think more of a genetic metabolic workup. And so, you know, standards for us as clinicians are chromosomal microarray and Fragile X testing. So sometimes that doesn't always pick up more specific genetic diagnoses. And so I think we are getting better about maybe even moving toward whole exome sequencing or other panels where we include certain genes. So perhaps Syngap1 would be included within a genetic testing panel that we send for kids who have these kind of prominent gross motor delays at a very early age. I would say in all of my reading and the patients that I have had the chance to see thus far, some of those other distinctions are really the ataxia and unsteady gait component and the epilepsy and the type of seizures that are seen. I'm not a neurologist, but I do get the sense that there's kind of a characteristic type of seizure those may be other hints toward leading one to test specifically for Syngap1. Okay, and I, as a developmental pediatrician, I often get the question, why do some, but not all children with Syngap1 mutations have autism or kind of other developmental behavioral diagnoses like ADHD? So some children might have been given those diagnoses and others may not have those diagnoses. And so why is that if they all share the same genetic diagnosis? And the answer to that is because genetic diagnoses and developmental diagnoses are different. And what I mean by that is a genetic diagnosis is based on highly accurate laboratory genetic testing. So we have an answer on paper written down kind of exactly where, you know, the gene has been edited or deleted, and it gives an etiology or a reason for a child's presentation. And it can also alert us to potential medical or developmental findings in the future. Whereas developmental diagnosis is not diagnosed using blood tests or brain imaging, which I think contributes to a lot of the kind of gray area around some of these diagnoses, because we can't kind of go back to an objective blood or imaging test to tell us whether or not a child has a developmental diagnosis. Rather, these are, quote, clinical diagnoses because they are diagnosed by professionals or clinicians based on the child's developmental history. So what we learn from you as parent or caregiver, and observed behaviors that we see during the visit. So depending on how long the visit was or what's going on, you know, you can see how you may or may not see certain behaviors within a visit. And the symptom criteria for these diagnoses are described in this picture of this book I have here, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So you can see there's another layer there because it's the 5th edition. So that means there's been 4 other editions before. And so these definitions are even getting revised over time. So it can be quite confusing when it comes to developmental diagnoses. So genetic and developmental diagnoses are related, but not the same. A genetic diagnosis often doesn't tell us what specific developmental and behavioral symptoms the child has or will develop. Like I was saying earlier, you know, Dr. Holder said, I still can't really make predictions based on what I know about the genetic finding and kind of where it is as to what the ultimate developmental outcomes will be for any given child. And so I want to talk some more about definitions and how do we actually make these developmental diagnoses, since that is my area of expertise in all of this. So I'll start with intellectual disability and how it's defined in the DSM-5 as pretty much the vast majority of individuals with Syngap1 mutations will have intellectual disability. So this is defined as, number 1, deficits in intellectual functions, which just means there are challenges with reasoning, problem solving, planning, judgment, learning, and that results in deficits in adaptive function. So that is defined as an inability to meet developmental and sociocultural standards for personal independence and social responsibility. So, okay, Dr. Harris, you've given us a definition, but how is that, that's how it's defined, but what does that actually mean and how is it diagnosed? So for the first point, deficit in intellectual functions generally translates into performance kind of in 2 standard deviations below the mean. So if 100 is kind of the average mean for the population, an intellectual quotient or an IQ of below 70 would be in the range of intellectual disability. So how is that measured? It should be measured with an individualized, standardized, culturally appropriate, psychometrically sound measure. And so that's a lot of words in there, but those tests are often administered by a psychologist, either at an outpatient facility or in the school setting. A brief version of one of these measures can be administered by a clinician, such as myself, a developmental pediatrician or a neurologist. And so if you come to our clinic at Texas Children's, I'm usually doing this one here, the cat clams on the left. This middle one is called the Stanford Binet. It's a common one used by psychologists, and that's a little more like intense and in depth. But as you can see, there's a lot of limitations to these types of measures. So what about children who do have fine motor, gross motor difficulties, and you're asking them to manipulate small objects, or maybe they don't use spoken language. So those components of testing don't seem as relevant. So we are getting better at trying to tailor these types of measures to different populations. But it's still definitely not a perfect science. There are some tests that are completely nonverbal. So it removes the language component and you're still trying to assess problem solving without needing to rely on expressive language. But there are other factors that go in, like did your child sleep the night before and how are they feeling that day? And are they comfortable with the examiner? So these types of tests give us a number that's like 1 point in time, but it can be useful to give a baseline to see where things currently are and where to go from there. So that's point 1 of that definition. And then 2 would be adaptive functioning, and the severity of one's intellectual disability is actually determined by this part, by the adaptive functioning. So, you may score at a certain level on an IQ testing measure, but what does it actually mean in your day-to-day life? And that's what we actually use to determine how severe it may be. How much is it impacting the child's ability to care for themselves in any way? So this is assessed by measures such as the ones kind of listed here as examples. So you, as parents or caregivers, may have filled out an ABAS or a Vineland, and it goes through all those different areas. And so we rely on parent or caregiver to tell us kind of in the day-to-day, what is the individual able to do and how are they functioning? And then you can see here kind of, it's still that 70 or below is still kind of when it falls into the intellectual disability category, and you can see how it's broken down: mild, moderate, severe, and profound from there. Okay. There were a few other clarifying points I wanted to make about intellectual disability. One is that you may hear clinicians say cognitive delay or difficulty in cognitive functioning. And really, all of those are ways of describing intellectual disability. And intellectual disability, or ID, is invariably accompanied by delays in speech and language, fine motor skills, and gross motor skills relative to age. Because if you think about it, a process that affects the entire brain and neurobiology, such as the Syngap1 mutation, is going to affect, everything broadly. So you're going to see delays in all of those areas because it's all because the process is affecting the whole brain. And so I also wanted to touch a little bit on what can one expect. So practically speaking, when we give one of these designations for intellectual disability, what does that actually mean for the individual? And I'll preface this by saying we make generalizations based on kind of over time what we've seen and learned from individuals who fall in these different ranges, but none of it is hard and fast. Each child is unique. Children surprise me all the time. So I always tell parents, these are just guidelines. We want to give you some clarity and kind of what to expect, and don't want to and want to be honest about that from what we do know, but also realizing that we don't always know all the details. And so every child, like I said, always has the capacity to surprise us. But if an individual has profound intellectual disability, we think about that individual functioning around 3 years of age. And so we usually recognize profound intellectual disability well before 2 years of age, because the delays are very prominent and very early. Similarly, with severe intellectual disability, we think about ultimate functioning at around 3 to 5 years. And that's usually recognized again before age 3. Moderate intellectual disability, individuals function around 6 to 8 years on average. And we usually can recognize moderate intellectual disability between 3 to 5 years of age. It's a little bit, it's not quite as prominent, so it takes a little bit longer sometimes for teachers, parents, doctors to recognize that there might be a delay. And then mild intellectual disability, a lot of individuals in the community have mild intellectual disability, and that it may never be formally recognized, or if it is, it's usually after age 5 or 6, and when the child is in grade school and maybe having some academic struggles. And ultimately, those with mild ID can be 4th to 5th grade level in terms of reading, basic arithmetic, writing, filling out a basic job application, things like that. So I did want to touch on that because I think a lot of times we use terms and parents want to know, what don't really know, okay, what are you actually saying with that? And what should I expect? And how do I, convey information to my child? And while sometimes I think it's hard to think about these things, I think it can be helpful because if okay, my child is more in a certain age range, it will change both maybe how you communicate or kind of how you teach them, because it can help reframe. And teaching them at their level is extremely important for then taking them to the next level. Because I was discussing this with a family the other day, that it doesn't mean that the child will never the child will never learn new things, because anyone can learn new things. It just might take a lot more practice, or might take saying it in simpler terms. And that's where kind of knowing these expectations can really help us help children to achieve their maximum potential. And so lastly, a word about the term global developmental delay. It's something else you will hear kind of in this journey. Clinicians often use it for younger children who have delays in all domains of development. So global, meaning it's speech, fine motor, gross motor, problem solving. And we tend to use this term in younger children because it's really hard to make a determination or about intellectual disability until a little bit later, because that early time frame is such a time period for rapid growth and change, that we're not comfortable committing to anything for a while in terms of what to expect. So global developmental delay is used in younger children. It can potentially signal that a child will go on to have intellectual disability. Not always, but a lot of times it's, for us as clinicians, when we see that, we're thinking, oh, this child may have intellectual disability in the future. Okay. I'm going to check my timing. So, because now we're going to move on to talk a little bit about autism and how it is defined in the DSM-5. So autism is separate from intellectual disability. And I think that in and of itself can be confusing sometimes. Autism just talks about difficulties in 2 areas. You'll hear them called criteria because that's how this book describes it. So there's social communication deficits or difficulties, and those are the A criteria, and then restricted and repetitive behaviors, and those are the B criteria. So for a child to have autism, you have to meet all of these A criteria. So one is deficits in social emotional reciprocity, so kind of that back and forth exchange. People will say, back and forth conversation. Well, for a child who doesn't use conversation, that's even things like, a parent does peekaboo, the child responds. So it's that kind of back and forth with a parent or friend or caregiver. And then the second is deficits in nonverbal communication. So those are things we ask about, like eye contact, and do they point, or are they trying to use other means to communicate with you? And then the third is difficulties in developing and maintaining and understanding relationships. So what does that look like for a child with delays? It can be just as simple as just preferring isolation and not other individuals. Or we often look at how a child plays in order to give us an understanding of relationships. That's how it's manifested in early childhood, is through play. So seeing if they kind of play in a creative way, or do they really just become centered on an object and not so much people around them. So you need all 3 of those, and then 2 out of these 4 for the behaviors. So those are things like repetitive motor movements or speech, Insistence. The second one is insistence on sameness or inflexibility. This is where people ask about, did they have trouble with transitions? Many young children do have trouble with transitions. Anytime we're talking about autism, we're thinking, okay, is this above and beyond what we would expect for a child this age? And then the third is highly restricted or fixated interest that are really abnormal in their intensity. They really can't be moved away from one given thing. And then the last is this hyper or hyporeactivity to sensory input. And so you can see how autism gets confusing because it is just defined by these behaviors that are determined by a clinician based on what parents tell us and what we see of the child. So all three of those 8 criteria on the left, and then 2 out of the 4 of these. A lot of times in genetic disorders such as Syngap1 mutations, clinicians will kind of use this term autistic features. And so when I hear that, I often take it to mean that the child doesn't necessarily fit all the hard and fast criteria for autism, but does have some of those symptoms, just maybe not kind of the full picture. I think a little bit of a tangent to that is that can be really challenging actually, because sometimes if the child doesn't meet the full autism criteria, and so therefore there's not a diagnosis of autism, that can sometimes impact access to therapies, which is unfortunate and should not be the case. But I did want to present this information because I think it can be confusing to family members, caregivers, providers, that why do some children have autism and some don't? A lot of times it's dependent on the clinician or just the day that they were seen in clinic or the report of these symptoms, because it is just defined by those things. And many children with Syngap1 mutations, from what I've gotten to see so far clinically and from what I read, have a lot of these features. I mean, obviously there's going to be social communication deficits. We know that sensory differences in how they process sensory information is a feature that we've seen. In fact, one of our clinicians here did a whole study at kind of the patterns of sensory processing in Syngap. So we know that that's there. So anyway, I wanted to kind of touch on that, and I'm sure there may be questions, and we can talk about that. Because and this is another thing that comes up a lot: autism and intellectual disability. It can be confusing because some children have one, some have both, and you can see how those symptoms overlap between the two. Like I was just mentioning, delays in communication, repetitive or stereotype movements can be seen in both of these diagnoses, sensory behaviors. Other behavioral challenges, inattention, hyperactivity, aggression can be seen in either or both of these diagnoses. Adaptive and learning challenges and difficulties in making same-age friends is going to be kind of a part of both of those. I won't really belabor this point just for the sake of time, but we can go back to it if those are interested. There's certain things that I, as a developmental pediatrician, can look at to try to tease out these two, but I'll save that maybe for questions. And then there's this big bucket of, quote, behavioral difficulties. So examples like inattention, hyperactivity, aggression, self-injury, impulsivity, eloping, and that means running out of the room. And physicians tend to like to categorize things under, diagnostic labels. So we may characterize it by using a given term, like attention deficit hyperactivity disorder, ADHD. Usually that means inattention, hyperactivity, impulsivity. Someone might say, I think this is because of anxiety, so I'm going to use the word anxiety to describe these behavior difficulties. Or there's something called disruptive mood dysregulation disorder, which is kind of a catch-all term for some of these challenges. But I like to just put that out there because I think it's another confusing area where, you're like, why are some children labeled as having ADHD and others don't? Sometimes it's just how we're trying to describe a behavior that we see. Okay. I was going to take a question break, but maybe I'll just plow through and then just leave a lot of time at the end. I know because I wanted to touch really quickly on what we can do to help, right? Because I think that's another huge thing that we're seeking out of these talks. And I think it's incredible that you guys have this collective group that's interested in Syngap1 mutations, because this is what's going to foster, how do we gain the knowledge and disseminate it quickly? And then how do we figure out what is the best way to help these individuals? So when it comes to intellectual disability or global developmental delay, our best support is therapeutic services. So speech therapy to target speech and language delays. And in Syngap1, along with many genetic diagnoses, it's really critical that this involves some form of augmentative communication, which is just our fancy way of saying something other than just verbal speech, because verbal speech is going to be difficult. So we need pictures, we need some type of maybe a device, or even just simple communication buttons off of Amazon where you can put your voice on them, and that gives your child a way to communicate a choice, because that's really going to be critical over time. And one of the best things we can do is give our children a way to communicate with the world. So you always want to make sure, if possible, your speech therapy has some type of augmentative communication. Occupational therapy, that's going to address hand use, adaptive skills, toileting, daily living skills. And then physical therapy is going to work on the balance, the core strength, the mobility, the hypotonia. And these hopefully can be found as an outpatient. And what I mean by that is, in addition to what you're getting at school, maybe you take your child to a center, maybe the therapist comes to your home. And I always encourage families do as many sessions as your child and your pocketbook and your time can tolerate, because all those things factor in. And at the end of the day, your child will let you know, how much therapy he or she can take. And it's really all a balance between what is most helpful to your child and most meaningful to your family. It's not about running yourself ragged, trying to get to all these services. Sometimes more time doesn't equal more gains. And so I always like to make sure that parents know that parents and caregivers know that you know your child the best, and you're the expert and you're the best advocate. So trust yourself in your decisions, and don't second guess yourself. Trust what you know to be true for your child, your family, your time, what you're able to do in that moment. We do think the more and the earlier we can do these services, the better. So just something to take away there. And then also you want to make sure the child has an individualized education program or an IEP, special education services through their school system. The school should be delivering speech OTPT as part of the IEP. So that's something else that you would want to see and expect. And there are behavioral therapies that can be very helpful. ABA, it stands for Applied Behavioral Analysis, is a type of behavior therapy that has a large evidence base and research evidence base for improving daily living skills and cognitive skills when it's given in high intensity and at young ages. And in autism. So that's where all the research has been done, which is a little, in some ways, unfortunate, because then that translates to, because all the research is in autism, if you don't have autism, it's hard to access that therapy, which shouldn't be the case. We also know that this therapy helps with intellectual disability. It helps children build adaptive and cognitive skills. So it should work for any child. But even if the child does have an autism diagnosis, it's still hard to find because of this need far outweighs the supply of available providers. So I'll also say that there are a lot of very varied opinions around ABA, and many individuals with autism who are verbal and who can speak will say that they maybe feel it's too rigid or too kind of the basic form of ABA is called discrete trials, and they feel like it's I guess, again, too rigid and not flexible enough. So a lot of times, depending on the therapist or the way that the therapy was delivered, it can impact people's view of the therapy. As a clinician, I will say that we have found it can be very effective in helping with difficult behaviors, and sometimes it isn't a great fit for the therapist. So again, you're your child's best advocate. So if you feel like something's not right here, definitely listen to that and talk to your clinicians about it and figure out a way to find an effective provider. Essentially, ABA teaches parents more detail about how to figure out the function of the behavior. So why is the behavior happening? Because that's really going to inform everything. So then what do we do to help reduce the behavior, or what do we do to help build a behavior? That's why it's called applied analysis. So a lot of the therapy initially is spent just understanding the child, watching the child, seeing what kind of triggers these behaviors and how do we respond that maybe we're accidentally keeping that behavior going, or what do we need to do to change it? Because ABA is hard to find, I mentioned parent management training here because sometimes that can be more easily accessed, and it uses a lot of the same principles about how to build skills and how to reduce problematic behaviors by building positive behaviors. And I think my biggest quick tips for parents is to, at first, always consider communication. So many times the behavior is related to difficulties in communication. And so it's just the child's way of trying to communicate something. And then think about these other reasons, maybe they're sensory overloaded, or they're bored. They're maybe, giving them something else to do with their hands might just completely distract from the behavior. It could be pain. I know as clinicians, we think a lot about, could this be constipation or dental pain? And that maybe the child doesn't know how to tell us what's going on. Oftentimes it's just to obtain something that they want or to get out of something they don't want to do. And in those instances, it's hard because the answer is to stand strong and not allow the behavior to get the desired goal. And some are just automatically reinforced, and those are the hardest. That's where we really rely on our ABA therapists to help, because that just means that we can't figure out why it's happening. And it clearly serves a function for the child, but we don't know what that is. And so we don't know how to help that. And that's where behavior therapists really will get down to some very specific analysis. And I just to say explicitly that obviously it's important to remember cultural considerations and your family context, because that informs our expectations or practices and how we interpret behaviors and how we respond to them. Okay, and a few last thoughts. Therapeutic and educational interventions should always, particularly when we're thinking about individuals with Syngap1 or individuals with intellectual disability, should always focus on functional adaptive skills and improving independence in your day-to-day life. It's not like, while it's great to do counting and things like that, like sometimes it's better to focus our time on functional skills that are going to help us communicate in the world and be more independent in the day-to-day functions. I already mentioned some of the issues with access. Access can be a huge challenge for any of these therapies. Again, I want to reinforce that augmentative communication is very key. And that last point, practice, practice, practice. I think something that is both probably encouraging and also overwhelming is that you will have to reinforce the skill day after day, teach something again and again. And it may feel like I've done this a lot of times, but because of those cognitive delays, it's going to require a lot more reinforcement for a lot of these skills. I remember speaking with Dr. Vincent, who's a neurodevelopmentalist who's worked a long time with Syngap1 patients here. She's about to retire, but her saying was always if you're trying to teach something, teach it again, day after day, every day, until the child has mastered it for a long period of time. And then you can finally stop teaching that particular skill. And so ideally, all the therapies and educational interventions will come first, but obviously there are medical interventions that we can do, medications for some of these behavioral challenges. That is a whole nother probably lecture in and of itself. It's confusing. I feel like a lot of times for parents, I'm sure this feels like trial and error, because there's a lot of types of medications we can try for ADHD-like symptoms, impulsivity, aggression, and attention. And each child is very unique and different. Even medications that work the same way theoretically, one of them might work for a child, and then I'll switch. If it doesn't, I'll switch to a different one that technically works the same way. And that one might just be, the magic bullet for that child. So like I said, a whole nother lecture in itself, but I'm sure it can feel frustrating because sometimes we have to do a little bit of trial and error. My one rule for medications is never change more than one thing at one time, because then you might not know which thing helped or hurt. And rely on your resources. I know folks are listening from all over. So I'm in Texas, so I try not to list a lot of Texas specific things, but this foundation in and of itself, like I said, is phenomenal. A lot of states have waiver programs where, families can qualify for services that, it's irrespective of income. That's why they're called waivers. Just if your child has high needs, there are programs that can give you support. You just have to ask about them in your individual state. Easter Seals and the ARC, I think, are pretty, are not just in Texas. They're more broad organizations, and they can be really helpful of knowing your local therapies and resources, and your local intellectual disability agencies. You can Google LIDA in your area. And then there's a lot of info out there in terms of Syngap1 specifics, if you're interested in some of the more specifics around the findings and both medical and developmental in Syngap1. There are places to find that. And I think I will stop here. I'm a little bit over time, I know, for the goal, but stop here for questions. I can go back to anything as well.
That was great. Thank you. I really appreciate it. We've got a few of us here in Zoom, and I'm watching Facebook. There's 5 or 6 out there. So for the Facebook folks, if you want to use the short link, syngap.fund/ was it Holly or was it Harris? I think it's Holly. It's in the link. You guys can join and ask questions live. I have a bunch of questions, Dr. Harris.
Okay.
Where to begin? So let's start with, so I appreciated you talking about the ID, because I mean, almost all of our patients have that, except for those who were mild, which you pointed out. There's one in Dr. Holder's set who is oddly mild. I'm very familiar with that case. I will observe that within our patient population, we have a couple, the 5' is the beginning and the 3' is the end. Is that right?
Yes.
Yeah. So in the Vlaskamp 2019 paper, they observed that mutations in exon 1 through 5, so the 5', are generally a milder phenotype. And we have identified the 333 DELs, C33 DEL, and as a 192 DEL. So people with deletions really early on seem to have milder phenotype. And then the case in Jimmy's data set is C3583 -9. So that's an intronic over by exon 19. So really the takeaway there is any mutants that are in the ends where you start getting into isoforms seem to be milder. Broad observation, not yet backed up by science. There's a fellow at Boston Children's Hospital right now analyzing the citizen data who will hopefully be able to validate these hypotheses with the 170 plus patients we have in citizen. So that's just, I just wanted to mention that. And then to come to the autism, you mentioned 53 and 73, and I think the 50% number comes from the Vlaskamp 2019 paper, which was an international cohort. And the 70-ish% number comes from the Jimenez Gomez paper, which was, I think, primarily a US cohort, right? And I think that's always struck me, right? There's 2 things there. If I characterize those 2 populations, the Vlaskamp population was an earlier population, right? It was more of Ingrid's work, more global. And it was more global, earlier and global, whereas Jimenez Gomez, more recent, more US. So it's safe to say that, wow, the number was much higher in a more recent population and a US population, right? And I think in the US, agreeing with everything you said, the cold hard reality is you can't get access to ABA or countless other services or waivers or, forgive the expression, damn near any support in the absence of an autism diagnosis. So in the US, people have had to, parents have had to work really hard in 2 short meetings with well-trained clinicians like yourself to navigate that A-B checkbox rubric and get all the buzzwords to get that diagnosis. And so I really appreciated how you broke that down. But here's the question. Now, speech complete. When I'm talking to Syngap parents going into those meetings, I literally tell them, give your child 2 Snickers bars, 3 Red Bulls, kick them in the butt. Don't let them sleep the night before. Like, just the goal is property damage, right? Send them into that room and destroy the building. Like, make it so the clinician cannot possibly not give you an autism diagnosis. But the reason, but to be a little more serious, I do say that, but to be a little more serious, what I've observed in Syngap is the phenotype is broad and takes time to set in. And the trouble with a 3 to 5-year-old Syngapian is they still give everybody, the parents included, a false sense of security. So they walk into that clinician's office, they look you dead in the eye, they've seen this movie before, it's like their 20th appointment, and they see Dr. Harris and they smile because they know that's how they're going to get out of this room, right? And it's not going to be until they're 4, 5, 6, 7, 8 that their elopement and their aggression and their fixations become more pronounced. So what I hear parents say as the person who they come to when they're at their wit's end is, I went to get the autism diagnosis. The doctor disqualified me because the first thing the kid did was smile at them and they're like, this kid's not autistic, which I think is too simple and sort of over indexes on eye contact.
Yep.
But then what I say to them is, go back and fight harder because the presentation has evolved, right?
Yes.
So the question is, like, how does a parent re-engage the developmental pediatrician or the ped or the whomever to make that argument look the phenotype, like what are the buzzwords they need to use to get that reassessed?
Yeah. Oh, that's a great question. I think it's very challenging because I think even within, primary care pediatrics, I mean, I think about even as we are educating learners that are going out to be primary care pediatricians, autism is still, there's still this sense of like, oh, if the child smiled or looked at me in the eye, they don't have autism, which that's not the case. Just like you were saying, like in general for any child, there's a lot more subtlety to it. I think your point of going back and fighting harder is a good one. Sometimes, depending on where you are, depending on the clinician and how maybe, for lack of better terms, rigid they are about certain things, it may be worth getting an outside opinion. I think a lot of us, because these are just these descriptive diagnoses, a lot of us, like you're pointing out, I think of it as autism is this big umbrella, and there are genetic syndromic forms of autism where, like you were saying, like children with Syngap1 mutations have these features that are part of the criteria. And because of the way things are, it is unfortunate and a disservice to maybe not just acknowledge that from an early age. But as far as like, if you're not seeing someone who understands kind of that whole spectrum, like what to say or what to do, I mean, I think one part is just showing that knowledge, like speaking to others in the foundation who have walked that road, going in there. I think if you go in as a parent and you say like, look, I know what autism is, and let me tell you how they meet this criteria from my standpoint. I think in some ways, maybe that's the best way. It's kind of looking in the DSM-5, and because if you go into a provider with that level of knowledge and you're able to give examples from your child in the home setting, because it should be based on history and observations. We're not going to see everything in 2 hours. So that would probably be my biggest piece of advice, is to know that criteria. And especially like you were saying, I think the sensory, the behavior side is more obvious, but the social side can get confusing because someone might smile at you once or whatever. So if they can really articulate where those deficits are in social, back and forth, and you would think it would be clear, but I think if they can maybe argue in that perspective, that might be helpful. But yeah, it's a great question.
Okay, next question. I'm gonna keep coming. You said something that woke me up. You said, our standard is CMA for Fragile X. And the reason that makes me crazy.
CMA and Fragile X.
Okay, fine, still makes me crazy because our kids tend to present like Fragile X, and a chromosomal microarray will not catch a Syngap mutation.
Correct, yeah.
Right, so that's time wasted. And as of a year ago, and I must have misunderstood what you said then, because as of a year ago, the ACMG was like, first line testing for kids with ID under 18 should be exome or genome. So like but literally the vast majority of our kids get waste time and money getting a chromosomal microarray. And unfortunately, many people are told when that comes back negative, it's not genetic, which is just like, right? Generally by older clinicians, you're recently trained at exceptional institutions. So I'm sure you would never say that, but it kills me when, why are we even doing CMA anymore? Why aren't we just punting it right to exome and genome? Is one question. And then I wanted to share this with you. I recently spoke to, let me share my screen for a second. I recently spoke to GeneDx. So this is a slide I put up at the GeneDx All Staff. And based on our first 90 patients in Citizen, here are my top sources of diagnosis, right? So GeneDx by far, by a mile with 33 is a third of my diagnoses, right? Invitae coming in second with 21, but there you are, Baylor at 13. But when you double click on this, and I didn't have room for the Baylor data, 8 of those 13 are whole exome trios, right? It's at the and Gene and Invitae is more of the panel. But I'll tell you from side conversations with them, Invitae has 2 VUSs for every hit, and GeneDx has 1 VUS for every hit. I actually don't know the Baylor numbers. I should find them out. And I think that's because the Invitae system is, it's a panel. It's more automated. It's quicker to VUS someone.
Yeah.
But my point here is, I guess I'm asking, isn't the standard of care, like when you just said we do CMA and Fragile X, I was like, no, but we shouldn't. We should be doing exome and genome, or at least the panel, right? I just want to make sure I heard that right. Or
unfortunately you did, because I think, and your question is why. So I agree with you. Based on the most recent publications, the most literature you read recently, whole exome, we should be doing whole exome. On autism, idiopathic autism, we should be doing whole exome. On anything, we should be doing whole exome. But the insurance companies do not agree. And so a lot of times what is out there in literature lags behind the widespread uptake amongst clinicians. I think because if you're the luxury of being in a larger institution, many times I will just refer my patients directly to genetics because they have Invitae relationships with Invitae panels. They have saliva testing within the department. They are able to better advocate for authorization. They are able to, but still many times they will start with CMA and Fragile X. And then once those are negative, only then can they advocate for the whole exome, and the parents not have to pay out of pocket. So sometimes it's a function of that. And in addition to the genetics organizations like the American Academy of Neurology and the American Academy of Pediatrics, like their statements still do not, I think, say whole exome. So it's a lot of people just wait for everyone to be on the same page. I do think I'm fortunate to be at Baylor where there's very strong genetics.
Yeah, no, absolutely. I love it. And I mean, if insurance doesn't cover, if a child has seizures, right? If insurance doesn't cover it, behind the seizure would cover the Invitae panel.
Exactly.
Right?
Exactly. So then,
circuit that.
Right. Exactly. So there are ways that we should be able to get around that. Especially if there's some other type of medical finding, seizures, even if I can argue for some type of, polydactyly or some other quote unquote syndromic medical finding, then sometimes we have more success.
Well, I would also say we have a partner in Ambit and also another one coming online soon, who we can send someone to them and they will do free testing. So even if for whatever reason behind the seizure is not an option, call us because I hate chromosomal microarrays. I hate them. Almost as much as I can't stand insurance companies. Okay, so we talked about that. Repetitive behavior, DMD. Oh, you mentioned meds, and I don't want to try to get you on the record talking about meds because I realize that makes doctors very nervous.
Okay.
And
I actually don't prescribe a lot either because I'm a developmental behavioral. I do, but anyway, go ahead. I'll try my best.
Well, but I guess so when you suspect, I guess that's a 2-part question. And the first is when you suspect a child needs meds, you refer to psychiatry?
No. I do start.
Good. So then, because the thing that I've seen, again, I do this full time, and I've done this full time for a few years now. And so I get on the phone with parents, and what happens is this is changing as genetic testing is happening earlier for ID. But the average course is seizures lead to genetic diagnosis, lead to neurology, lead to anti-epileptic drugs. And then the seizures are under control, and then the parent starts dealing with the sleep and the behaviors. And they come to me and I'm like, well, what meds are you on? And they rattle off all the usual suspects, all the AEDs. And I'm like, anything for anxiety, anything for impulse control? And they're like, no one's ever talked to me about that. And I think you did mention anxiety. When you get past the AED conversation, the next two conversations I have are, first, ask your doctor to think about, like, does your child feel anxious? Do you think there's anxiety, right? I mean, one of the smartest parents in our group, who's got an adult child and has a PhD herself, and we were talking, it's a whole other conversation. I said, what is kindness for a Syngapian? And she said, kindness is consistency, because anything else messes with their world and creates anxiety. And so, while all parents are terrified about what's happening to our children's livers, and I'm not necessarily pro medication, I have seen in my own son anti-anxiety and anti-impulsivity drugs make his days easier to get through. So I'm curious. So question for you there is, how do you feel about that statement? / how do you think about sequencing, discussing or recommending those meds in the context of AEDs? Because I feel like AEDs always happen first, and that's probably appropriate. And then I have a second point, but I'll let you answer that one.
Yeah. So I think I agree with your statements that you've made. I think it can be extremely helpful to address impulsivity, anxiety, and that's how I approach it. I think I have a lot of discussion with the parent about what we think is the driver of the behavior. Is it just purely inattention, impulsivity, like it happens, child can't even inhibit, or is it rooted more in, no, there's clearly things that make him or her anxious, and then we see it, because that would affect like the choice as to whether you kind of go more anti-anxiety route or you go more anti-impulsivity, ADHD meds type of route. I think it is challenging when you're already on anti-epileptics, more so just from the standpoint of like, you just have to look out for interactions and things like that. But there are plenty that can be used hand in hand, and that we often do use hand in hand. If I'm ever unsure, I'll just consult with a neurology colleague about, what do they think is the true risk? And the tough part is sometimes there are risks, but in reality, like what are those risks? What are the risk benefits for this child and the degree and severity of this behavior? And so sometimes it is kind of a peer-to-peer conversation. But I don't know if that answers your question, but I think you have to figure out like, what's the root? What do we think is the root? And then just try something. And like I said before, one thing at a time, and don't be too timid. I mean, if it's okay, go up, see maybe that child's metabolism is higher or whatever the case may be.
Which gets us to pharmacogenomics, which I won't ask you about, but it's my new favorite topic.
Oh, cool.
I think we should do them on all Syngapians, because I think what's risky is an untreated Syngapian who's impulsive and anxious.
Yeah.
In society, I think it's terrifying. But so the last question, and then I'll open it up. Actually, 2 more points. I always have 2 more points. The one thing you didn't mention that is the next thing I always ask parents is GI. And I'll just flag it for you for the next Syngapian. When parents are losing their mind and they're like, blah, 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 drugs, behavior, house torn down, child eloped, whatever. I'm always like, when is the last time they pooped? And they're like, why are you talking to me about poop? And I'm like, well, when our kids get backed up, seizures and behaviors skyrocket. And I've seen this like again and again and again and again and again. And I think it's something that people just, people don't intuitively index on when was the last time my kid pooped when everything else is going wrong.
Yeah.
But, and again, I don't have the hard data on this yet, but I'm sure we're going to get some soon. The trifecta, including Jimenez Gomez, right? Jimenez Gomez, Dalman, and Moshiri are these 3 doctors working on GI issues for Syngap over in Florida right now. And I'm sure they're going to show this some way. When our kids get backed up, things fall apart. And I'm wondering if that's what triggers you to refer to GI or to think about that?
Yeah, no, and maybe I should have like made it more of I think I was rushing towards the end to make sure I finished, but in the last slide about my first quick tip go-tos for behaviors, communication, and then in the other category is pain. And I as a clinician place, dental, constipation, I place a lot of those medical reasons under that. But I'm glad you brought it up because I think constipation is by far, if I'm thinking anything medical, is by far the first thing I think about, the first thing I ask about. And I agree. A lot of times I think sometimes even kids, even if they are stooling every day, pooping every day, whatever term you want to use, it still might not be that they're cleaned out. I mean, there's a lot that could be in there and they're still pooping every day. So I talk to parents a lot about that. That maybe it's worth just a trial of a weekend clean out, and we'll do, hit it hard with a couple of medications for a few days when you're going to be at home, and just see if that helps. It's not going to harm to try to clean it all out. You might have a few miserable days of diarrhea, but then you might see a great improvement after that. So just have to make sure your kid stays hydrated. But again, there are ways that we can, I agree with you. I think that's a common one that does get overlooked because there's so much else going on, but it's something easily potentially treatable.
Yeah, there's a lot there. A lot there. Interesting. Okay, so now I'm gonna go turn to these questions that have popped up in the chat. Lauren is doing God's work translating them because people are replying to Facebook. So, question about research related to environment, general education versus special education, specifically in the 3 to 6 range, and then the next one is also from him, Kevin, with regard to exposure from peers.
Yeah,
so
I think I understand. Yeah, I think I understand the question. So should we be doing general education and getting exposure to peers? Or are we missing out on that by doing special education, specifically in that 3 to 6 age range? That's a great question. I think part of it is, okay, if they're 3 to 6 in their chronological age, so that's how old they are, getting a sense from your developmental pediatrician, your school team, like where are they kind of cognitively? Are they more 1 to 2? Are they still working on some core skills? Because I think special education is best for when you really need that one-to-one practice, building some core skills. Because what you don't want, I think what lets me know that a child is ready for general education, or at least a little bit of integration into general education, is can they communicate in some fashion? Doesn't have to be with words, but can they communicate to you to let you know what they need? And can they navigate their environment and not completely disrupt the classroom environment? Because you do have to factor that in as an educator. And sometimes that they just might need a one-to-one, and so that's what we're advocating for, right? So this child needs some exposure to same age peers, needs a little extra support in that environment. Can we get a one-to-one for this many hours, and start a little bit at a time? Because I think, I think to Kevin's point, both settings are valuable for different reasons.
Yeah, I feel your pain on that one, Kevin. And then Dr. Harris, what type of specialists, if any, would you recommend our kids see for this disorder syndrome with varying diagnoses?
Oh, for the varying developmental. Yeah, and I think maybe asking who should they see because of all of the variability around developmental diagnoses, maybe. Because with Syngap1, I mean, certainly I would recommend a neurologist or geneticist. Sometimes that's the same person, depending on where you are. We have some neurogeneticists around here. And then I think for the developmental side, if you have access to a developmental pediatrician like myself, that's what it would be called, a DVP, a developmental pediatrician, that's ideal. A neurodevelopmental pediatrician, but those are also very hard to come by. In some states, there's one for the whole state. So you can, in terms of the day-to-day, helping your child therapeutically and educationally, schools and private therapists can do an excellent job of really giving you a good assessment of where the child is and what to do next. But in terms of making the diagnoses, that's difficult. Psychologists in the community can make diagnoses of autism and intellectual disability. So if it's something kind of you need to have that written down somewhere for your child, you can go to a psychologist in the community, which might be a little bit easier to find than a developmental pediatrician.
but if it's private, infinitely more expensive. And then
Exactly.
Verena asks an interesting question. Verena and I always find interesting topics for conversation. Verena leads, I should mention, the entire German community.
Oh, cool.
How do I see if it's anxiety or frustration?
Yep. But I mean, that's really hard. And that's why I think in my slide, I said, sometimes it feels like trial and error, and that's not, I mean, sometimes at some point you just have to try something. I think about anxiety when there is an environment, a change, something that you know, when my child sees this thing or gets in this environment, they lose it. They just can't hold it together behaviorally. To me, that suggests that something is anxiety provoking about that thing, that environment. Frustration, and like distinguishing that from frustration. So frustration can occur for many reasons. I think if you know that my child doesn't like doing this, and so that's when this behavior occurs, that I would see as more frustration. Like, I don't want to be doing this, I want to get out of it, not I'm fearful. Another, if you've given your child every option to communicate, so if you feel like there's a behavior, you've given them choices, you've tried to see if that's a need that needs to be met, or making sure you've eliminated that you've tried the communication side, because that could be another thing that's just frustration as opposed to true anxiety. I don't know. I mean, this is where you guys too are the experts. I don't know, Mike, if you've had you have thoughts around that?
I have thoughts about everything. I wish I could think less. I think it's anxiety. I think our kids are incredibly anxious. I think our kids are having more seizures than we can see. I think they're having more sensory issues than we realize. I think the open field of life is very stressful for them. And I have I am not an advocate of pouring endless amounts of drugs down our kids' throats. I think we have some of our older kids, especially, you find them on lists of meds that have just accumulated over time. And unfortunately, no doctor has said, wait, what's going on here?
Yeah.
So that's something I stress out about my own child. But I do encourage families to ask about, how about an SSRI? Let's just try it. Let's see. And anecdotally, I've seen good results.
I think, to your point, that's huge too, as a community, as a foundation, like gathering that anecdotal data, right? I mean, you are the ones that seeing and experiencing what's been helpful. And I think that's something that, as a clinician, I would find very useful. And it would make me help me not to feel like it's as much trial and error. If I'm like, okay, this percentage, like this population of Syngap1 families have told me that this has been helpful. I do it a lot, anecdotally. Sometimes when we're thinking about ADHD, and if a parent is like, oh, I have ADHD and I took this medication and it was like changed my life in a positive way, then I'm going to use that one for their child, because it's, I mean, it's the same family member. So there is information that we can gather anecdotally that can be really helpful when we're making these decisions where it's a little bit of trial and error.
And that's where the pharmacogenomics thing comes in, right? Like, I can't wait for insurance to start covering that, because I really think, especially when I study and talk to the older kids, like by kids, I mean the 20s, the 40s. Karen is 66, and when I look at the meds some of these adult patients are on, it's a lot of psychiatric support.
Yeah.
Cool. Other questions from the greater audience?
There was something in the chat on the one that I can see, the Zoom chat. Do you see a lot of paradoxical reactions to medications in patients with Syngap?
That must have been just to you. I didn't see that one.
Yeah. Oh, no, it's on that. Yeah. So again, this is where I'd love to hear from you. Because I don't know that my base is enough to make any generalizations of the patients that I've seen directly. I find that many children with, if it's any kind of given genetic diagnosis or developmental diagnosis, I feel like I never can guess how they're going to respond. I think it's always a possibility, and it's a little bit more likely in the populations that I see that it's going to do the opposite. I don't know. What have you guys seen?
So we have seen paradoxical. We have seen some crazy stuff. We've seen some on the AED side. I've seen paradoxicals to Keppra and Onfi. that were notable. And then I'm not a doctor, I'm not making medical advice, I'm sharing anecdotes. On the impulsivity side, some people have had great luck with guanfacine ER, and and that is a constant topic of discussion. And there has been a couple of paradoxical responses to that.
Yeah, those are common. The alpha
weird.
agonist, guanfacine, clonidine, those are common ones that typically do fine, but then some children, just the opposite. We're trying to help with sleep and behavior, and then it does the opposite. Yeah, it's hard, it's unusual, but
it's weird. And the other thing about our kids, they just seem to be so sensitive to meds. Like as small as change is just,
yep. Yep. And I think that's another good thing to take away is like your physician, that's another one of my policies. I'm sure. I think it's so hard because we want to do something, we want to help it and we want to fix it fast, but I always like one change at a time and like I'll be like inching up because of that, because I think it's like, you would think that this tiny dose isn't going to, make that big of a difference, but it might for some children.
Yeah. Well, the citizen data, I will say, is available to any researcher or clinician. So if you ever wanted it, you could get standardized normalized data on 100. I think the next data release will be in about a week, and there'll be 150 patients there, including their full med history.
Yeah.
So you can just
That's
some pivot
amazing.
table work can show you pretty cool stuff.
I think part of it too is just like education. I mean, I'm even thinking about as a developmental behavioral pediatrician, like how do we disseminate things quickly? I think, going back to like the genetic testing piece and like, like yeah, people have found out a lot of good information and we're just not disseminating it fast enough because
Actually,
like you're saying, that's news to me. I need to go look at that. So
here's a question. I mean, a lot of my questions, I have an agenda, as you can tell, but like this one is a sincere question to you. Parents come to me and they tell me something cool that happened. And I was like, oh my God, that's so fascinating. What's the magic words I or the parent needs to use back to the clinician to get them to write up a case report? Because there's some really interesting things that I think are either sentinel for our community. Like I've heard this story 5 times and I wish to God it was in the literature, or so weird, I want people to know about it. How do we encourage overworked, overscheduled, tired, but very capable clinicians like yourself to write a short case report and get it into the literature?
Ask them if they have a med student.
And then what's the appropriate stipend we can offer that med student? Like, I'm willing to pay for this stuff. We really need these stories to be told.
Yeah, no, I completely agree with you. I think, I mean, in full disclosure, like my brother has autism, and I think some of the most fascinating things I learned about autism are through my brother. And so it's like, I hear you. Like, there's just something there where a part of me is like, man, if I had all the dollars and time in the world, I would like research this thing that he's telling me, and figure out how to research that. But in seriousness, I think you're right with what the issues are: time and overworked. And if you can find a way to alleviate that, and then maybe we can talk offline about a stipend. No, I'm not sure. I'd have to think about that. But I do agree with you. Like, don't give up on it, because I think that is how we're gonna have to get the information out there, is through writing up the things that we learn from families. Oh, cool. Sorry, I don't want to forget, Tim also asked a question about the cost difference between the CMA and a whole exome. It's much closer now than it used to be, but yeah. But do you actually know that? I don't know the numbers off the top of my head.
I mean, CMAs are dirt cheap. I think insurance gets away with we're talking, like I think of it in terms of digits, right? CMA is 3 digits. An exome or a genome is down to low 4 digits, whereas it used to be 5.
Yeah. Good summary.
But privately, Tim, I mean, private pay, you can get these for not much. And like I just said, like through our partnership with Ambit, which I haven't even announced yet, like things are happening so fast, they can't even announce it. But through our partnership with Ambit, through Behind the Seizure, if someone needs testing, we can get them testing, right? We really need to find more patients because they're out there. Cool. Oh, I one point of order as you keep doing this great presentation, Dr. Harris. You mentioned the Syngap1 Foundation. I've heard of them, but they're not us. We're the Syngap Research Fund. I think colloquially we've been referred to as a Syngap Foundation, and it's odd that the other group changed their name.
I don't know
Some
if you
have
can
said they're
edit
trying
that
to
in.
impersonate us. I don't think that's really happening. But if you could just add the Syngap Research Fund to your slide,
Yes,
we'd love
most
it.
certainly. That I agree with you. I thought I was talking about the same thing, which is embarrassing for me, but
No, it shouldn't be embarrassing. I think it's intentionally confusing and and it's anyway. You don't have time for these details, but if you could add Syngap Research Fund,
yeah,
that'd be awesome.
of course, and then send you guys the slides.
Yeah, it's all good. We'll doctor the presentation. We'll just
I
put
was about to
ourselves
say,
in.
please do. I can even send you a clip of myself saying Syngap Research Fund.
No, it's all right. We got it. Olga?
Thank you, Dr. Harris. Thank you so much. That was wonderful. And we'll get you the information on Cook's Children's for the end of June. I think,
perfect. Wonderful for me. I learned from you guys. So
yeah,
awesome.
that'll be great. Andrade and Perry are good. And the Dravet meeting, if you weren't planning on going, there's gonna be a lot of heavy hitters there too, which should be some
awesome.
great clinicians. Yeah. And then thank you, Tim. And then next week we have what's next week's webinar, Olga? They're coming fast and furious.
Dr. Rumbaugh.
Dr. Rumbaugh on splice forms.
Yes.
Which will get to what we talked about at the top about the 3' and the 5'. And then the week after that is something else, right?
It's the probably genetic testing.
Finding more patients.
Yeah.
Awesome. All right. Thanks,
I
everyone.
have one quick question before we go that might help Dr.
Sorry.
Harris and help me understand too. She's talking about Fragile X testing, et cetera. Syngap is only coming up through the epilepsy panel, or, I mean, do we have a specific test that if Dr. Harris suspected she saw a Syngapian patient, she said, okay, can we send them directly for that test? Or it has to be the whole exome? Or
Dr. Harris, you want to take that first? You want me to?
You can weigh in because like I said, because I'm not getting the chance to send a lot of these myself, I'm having to refer out to genetics. I would think you could do sequencing specific to the gene, like that you can in some others, but I don't know if I don't know if you can do it.
So the answer to that, here's my answer, and I welcome correction from Dr. Harris. The CMA is like a 30,000 foot picture of the chromosome. Yep. And if a chromosome is misformed, like you would see in Fragile X, you get that. But it doesn't zoom in on the genes, right? Which is why it's so antiquated and cheap and relatively useless. But so your question is Olga, one of decisions, right? How do we catch a mutation in Syngap1? And that's why people prefer exome and genome, is because exome and genome look at the whole exome/genome and say, okay, where are their variants and what do they mean? And if they have a clinical indication of ID or epilepsy, whatever, they will zero in on neurological genes. But because it's cheaper, and this is rapidly becoming not true as the cost of exome crashes, to Tim's question, you're seeing these panels go away, but they're still cheaper. They're still easier to get through insurance. So people still do them. So we are on an epilepsy panel. Because of Peter from our board's advocacy, we are now on CP panels. We are on ID panels. So if you're on an ID panel, an autism panel, a CP panel, what am I missing, guys? There's probably one other. We have talked to GeneDx, Invitae, Ambry, Variantex, and others to make sure we are on as many panels as possible so that we can catch. And that's just a decision, right? There's 400 panels on the Invitae epilepsy panel, 400 genes on the Invitae epilepsy panel. We're one of them. And so when I talk to other rare groups and they say, how do we get on these panels? It's old school. You call the company and be like, put me on the panel.
Yeah, I think that's a good explanation. The CMA, I see it as like you're looking for big copy number variants. So it's a big chunk deleted or is a big chunk duplicated.
Yeah.
And so if the big chunk that was deleted contains the Syngap gene, maybe you could like make some differences. But yes, yeah, exactly. And then Fragile X is like completely separate because even a CMA will miss Fragile X. That one you're looking right at because it's a repeat sequence, a triplet repeat. So for that one, you're like, okay, I'm looking at that exact gene to see. Yeah, and then it looks like there was a comment too in the chat that Sanger sequencing. That's what I was trying to think of. You can
Yes, that's what I was going to bring up. Yeah.
You can sequence the specific gene. But interesting. So there have been families who've done that though, and it still came back normal. And then later the exome caught it. So it sounds like exome maybe.
I think Berena's other question is super interesting point. Verena is so smart. She's talking about, also Angelman and Rett panel, because
we did all of that for, took us 5 years.
And I wouldn't encourage someone to go look at Syngap just because, a Syngapian and an Angelman and an STXBP1 and whatever in the early years, they all feel pretty similar, frankly. And it only after a couple of years that they,
that's actually, that's a great point. A lot of overlap developmentally, like speaking just from my area of expertise with Angelman and like kind of the degree of the delay and how it presents. Yeah. Interesting.
The thing about the angels though, is our kids start as angels and then they visit the dark side until they're about 20.
Yeah. That is true.
In a schizophrenic manner, like 6 days, 20 hours a day, my son's awesome.
And then,
And then, aggression and behavior are real issues. That's why I look like this.
No.
Thanks, Verena. I'm going to check that out. Make sure.
Yeah, me too. Panels. Yeah.
Huh. Okay. Anything
well, thank
else?
you, Dr. Harris. We're grateful that you see our patients, and we're excited that you're fresh out of fellowship and you're so young and smart, because we need all the Syngap experts we can get in this country, because I see patients get diagnosed every week.
Yeah.
And they're coming.
Yeah, no, it's fascinating to me. I like I said, my area of research is autism broadly. I think the quote idiopathic autism is fascinating because we're going to find, what that is, but there's other forms. I do Angelman clinic here. I do Fragile X clinic, and I do MECP2 duplication and Rett syndrome clinic because of that reason. I'm like, they all have their own form of autism. It's part of their genetic diagnosis, right? And so yeah, we need to, anyway, back to our original topic of like the same type of services would be helpful. And so
funny story on
characterize them and just put it out there that, this is Syngap1 autism. This is idiopathic autism. It's all,
I can't wait to read your paper. You should really get a citizen
hopefully
data.
The way things move, it might be the years down the road, but thank you guys so much for teaching me as well.
I'll just funny story. Like there's a drug company working on Rett and Syngap1, and they had us present at an all staff. And so the Rett people have been around forever, right? They have way more money than we do. Very professional. They give a beautiful presentation. And Marta, who's a doctor on our board, presented our slides, which were my slides, which weren't as pretty as the Rett slides, but she did an amazing job presenting them. And then I got this question from someone in the audience about why is this? And I was like, guys, Rett syndrome was first diagnosed by Dr. Rett in 1960 something, right? You've had decades to diagnose patients. And then only in the 90s did we find MECP2 and say, MECP2 causes Rett. You have to understand, Syngap1, the gene was identified in 1989, the first patient in 2009. I have those numbers wrong. Round numbers, 1990, but 2009, first patient, right? We've only been diagnosing patients for 13 years. And the only way you get this glorious diagnosis is if somebody gets through insurance and gets a diagnosis on the gene.
Yeah.
So it's chalking, like, yes, Rett, Syngap, they roll off the tongue together these days, but historically, they've had so much longer to educate. People see hand flapping, they think Rett, and they diagnose. But Syngap, they're like, well, what am I doing? It's a totally different sort of way in, and a disease strictly defined by a genetic variation.
Mm-hmm.
It's just the system is still getting its head wrapped around it,
Yeah, it's a good way to put it. Still getting its head wrapped around it. But
people like you will help them do it faster. So we're grateful.
So I'll work on the DVP side of things, the developmental peds side, to get it out there.
Please do. I think you guys are essential.
Yeah. All right. Thanks, guys.
Bye, everyone.